Welcome back. Sorry for the small interruption. Let us start with, continue with our discussion. As I told you, whenever you have a severe hypokalemia, they can maintain alkalosis. Why? Because when you take a cell, potassium and H plus are in constant equilibrium with each other, which means potassium and H plus, inside also you have potassium and H plus, they are in constant equilibrium. Whenever there is a low potassium, they tend to give this potassium outside, and to neutralize that, they tend to take the H plus inside. So which means whenever there is a hypokalemia, there is a dynamic equilibrium that is happening, that is taking the H plus inside, which means there will be an intracellular acidosis. Intracellular acidosis. That's what is going to happen. And the same thing in a chronic hypokalemia, what will happen is there will be a low potassium continuously in the extracellular region. That will result in something called the intracellular acidosis. This intracellular acidosis will trigger ammonia production, because intracellular acidosis is a very important trigger for ammonia production. Why they produce ammonia? Because they are going to wash out this H plus in the distal nephron. Because whenever there is more acid inside the cell, they think that it's an acidotic condition. So to wash out that excess acid, they produce ammonia, and as a reflex response, they're going to wash out the H plus that is coming from the distal nephron. So in a way, hypokalemia can stimulate ammonia genesis. Hyperkalemia can reduce ammonia genesis. Hypokalemia can stimulate ammonia genesis, and by producing intracellular acidosis. And that is the reason why hypokalemia, if it is very severe and it's long-standing, can result in hypokalemia. If it's very severe and long-standing, can result in development of a chloride-resistant form of alkalosis, because here you have nothing to do with the chloride in the first place. Nothing to do with the chloride. And apart from that, loop and thiazide diuretics and the related syndromes, especially long-standing loop and thyroid diuretics, Bartter and Gitelman syndrome. Sorry, here you can make it a short use of diuretics. Short use of diuretics will result in a kind of a chloride responsive form only. In long-standing diuretic use, where the chloride is depleted, and in that setting, they will become a chloride resistant type only. So Bartter Gitelman syndrome, loop and thiazide. We know Bartter syndrome is like loop-like action only, but it's a congenital condition, so it's a long-standing condition. So Gitelman syndrome is thiazide-like condition, congenital, but it's happening for a long-standing time. Because it's a congenital condition, it will be there since birth, and it will be for a very, 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 very long time. So Bartter or Gitelman syndrome, both can result in a similar scenario that can induce a normotensive form of a chloride-resistant metabolic alkalosis. But nevertheless, as far as exams are concerned, only 2 points are important. When they give chloride responsive, think about vomiting and related causes. Whenever they give chloride resistant, think about hyperaldosteronism. This is the final take-home point. Even though I've told you so many causes, this is the final take-home point. Chloride responsive means vomiting. Chloride resistance means hyperaldosteronism states. That's what they're talking about. As simple as that. So treatment is very simple. For chloride responsive, you give sodium chloride, that is saline solution. For chloride resistant types, you give aldosterone. That's all. As simple as that. That's going to improve because it's due to hyperaldosteronism. So give some aldosterone blocker, like a mineralocorticoid receptor antagonist. That's all. You block the aldosterone action, like a spironolactone or eplerenone, and that's going to solve the debate. That's all. Very simple treatment. That's more than enough. So then, only 2 things are there. Respiratory acidosis is there. Respiratory acidosis is also referred to as type 2 respiratory failure. So this is completely based on the minute ventilation principle. Minute ventilation is equal to tidal volume multiplied by respiratory rate. We know that. So whenever you reduce the minute ventilation, you are going to increase the carbon dioxide in the body, resulting in respiratory acidosis and type 2 respiratory failure. So it can be, this reduction in the minute ventilation can be due to reduced tidal volume, or there can be due to reduced respiratory rate. As far as reduced tidal volume is concerned, more importantly, it will be a neuromuscular cause. So you can tell plenty of neuromuscular cause right from poliomyelitis, ALS, Guillain-Barré syndrome. then neuromuscular blocker toxicity, then multiple sclerosis. So many conditions are there. So neuromuscular causes can result in low tidal volume. Because of that, you might result in development of type 2 respiratory failure. As far as reduced respiratory rate is concerned, typical causes are the central causes. For example, if your head injury is there, stroke is there in the brainstem, traumatic brain injury, so benzodiazepine use, opioid poisoning. So these are the conditions where the patient will not breathe properly. So your respiratory rate will be low. Because of that, you will be resulting in respiratory acidosis. The details of that we'll be discussing later on anyways. So many causes are there, but respiratory acidosis, typical causes are these things only. Or the patient has an fatigue. I mean, low, it's not only neuromuscular cause, like even upper airway obstruction. Upper airway obstruction, especially if the obstruction is at the upper airway, like for example, a tumor obstructing the trachea, or probably a coin obstructing the trachea, or a foreign body aspiration that is present in the upper area, laryngospasm, obstructive sleep apnea. In all these situations, the amount of breathing, tidal volume you take itself will be very low. Lower airway causes can cause. Lower airway can cause. Here, the effective tidal volume will be low. For example, if there is more dead space ventilation. So we are talking about an effective tidal volume. Suppose if there is an alveoli that is not getting perfused properly, then even if the air comes in and goes out, they'll be devoid of CO2 only. And that alveolar CO2 will start getting accumulated. This kind of ventilation is called as dead space ventilation. That's called VD, that will be increasing. If the alveoli is there, but it's not effectively getting perfused, or if the gas exchange is not happening properly in that alveoli, then the air that is coming in that alveoli and moving out of the alveoli is effectively a waste. It's what we refer to as a dead space ventilation. And whenever you have a dead space ventilation, you can increase the carbon dioxide. The examples of dead space ventilation can happen in many scenarios. In acute exacerbation of COPD, or in patients who are having severe muscle fatigue. In all these situations, there will be a dead space ventilation only. Because of that, so many conditions can cause respiratory acidosis. So there's no need to talk about that. Then we have a respiratory alkalosis. But primarily, like as far as exams are concerned, it will be extremely simple. Low tidal volume or low respiratory rate. Low tidal volume means neuromuscular, low respiratory rate means central cause. If you know this much, that's going to be more than enough. As far as respiratory alkalosis is concerned, remember, many times it might be falsely telling you that the primary problem is respiratory alkalosis, but the problem can be type 1 respiratory failure. So you should never exclude this cause. Whenever you see a respiratory alkalosis, always first think about a type 1 respiratory failure. Because in type 1 respiratory failure, the characteristic feature is there will be low PO2 and low PCO2. And because of that, there might be increased pH alkalosis finding. But please understand the fact, this low PO2 should be seen. If you don't see that, and if you diagnose only this, there is no point in diagnosing respiratory alkalosis, and otherwise the patient will be dead in some time because of the respiratory failure. So always that thing should be the first thing that comes into your mind. And there are innumerable causes of type 1 respiratory failure, right from heart failure to pulmonary embolism to RLD to emphysema. You have numerous causes of type 1 respiratory failure, which I'm not going to talk about right now. Then there are some conditions that can produce a primary respiratory alkalosis. What are the conditions that produce primary respiratory alkalosis? In the setting, we're talking about a primary hyperventilation. There are some conditions that itself induce. Without respiratory failure, you can get hyperventilation. Remember here, the reason for hyperventilation and low CO2 is the hypoxia. The low PO2 is triggering the patient to produce hyperventilation and low CO2. But there is some conditions without even hypoxia, there can be hyperventilation. Best example is anxiety. Second example is a painful condition, severe pain. You will be breathing more. It can happen with some central nervous system infections like meningitis, encephalitis, abscess, and it can happen in fever. You might tend to breathe more. So you can extrapolate it to develop sepsis also. Or any drugs that stimulate the CNS like cocaine, caffeine, even too much of theophylline, too much of cocaine, too much of coffee. I mean, if you are taking very, very excess amounts. And then salicylates. Salicylates, they will typically cause metabolic acidosis with respiratory alkalosis. That is because of CNS stimulation directly. And many other drugs are there, many other drugs. So all these things can produce primary hyperventilation. Because of that, you can result in respiratory alkalosis. And remember, in these conditions, to tell it's a primary hyperventilation, you should not have hypoxia. Hypoxia driven means that is a type 1 respiratory failure only. If there is not hypoxia driven, then you can talk about a primary hyperventilation inducing a respiratory alkalosis. So these are the causes of respiratory alkalosis, and there is no, algorithmic approach as such, as we did for metabolic alkalosis and metabolic acidosis. So now we have learned a lot about metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis, the kidney function, and the basic rules of ABG, everything we know. Now, finally, we are going to the 6-step approach, the stepwise approach in ABG analysis. This is going to be the final nail in the coffin. So this is what you have been waiting for, and this is the most important, the stepwise approach for ABG analysis. As far as the stepwise approach for ABG analysis is concerned, the step 1, remember, first follow the basic rules. The step 1 is the basic rules that should never be forgotten. Whatever I have told you, that arrows moving in opposite direction means it's always a mixed disease. So what if one is normal and one is elevated? So that's really, really important. That's why follow the basic rules and never forget that in the first place. And in the bracket, you can seriously write the common sense. That's going to be the most important. In the entire medicine, common sense is important, but as far as ABG is concerned, this is really, really important, which means ABG is completely a relativistic phenomenon, and you cannot take any values as absolute value. Very, very important point. And I always write that a lot of common sense is needed to diagnose an ABG problem. And second, remember, these rules will apply. Whatever rules I'm going to tell from now on will apply only if the arrows are moving in the same direction. Only if the arrows are moving in the same direction, whatever rules I'm telling will apply. So make sure that the arrows are moving in the same direction before you go to the next step. So if the arrows are moving in the opposite direction, clearly it is a mixed problem only. So again, second point I'm telling, make sure that the arrows are moving in the same direction. So then only the next rules will be applicable. Now you might be arguing, arrows are moving in the same direction, but why should I go for further evaluation? Won't it be a single disorder with a compensation? That's all, no? Arrows are moving in the same direction means why you should think about another disorder. So remember, arrows are moving in opposite direction means surely it is mixed. This is 100%, no doubt about that. But if arrows are moving in the same direction, still it can be a single disorder or it can be a mixed disorder also. It could be an uncomplicated single problem or it can be a mixed issue also. How will you tell whether it's a single problem or a mixed problem? I mean, how can you really get that fact? Usually I used to give a common example. Suppose someone, let us assume is one of you is going in a bike, one of you guys, maybe let us take Ashwin, is going in a bike or maybe in a car. Suddenly one girl is coming with a dog and Ashwin has hit on that dog. I mean, fortunately not on the girl, and the dog died on spot. So let us ask Ashwin. So what will be the compensation that you can give to that girl because you did a mistake, and that's not right, isn't it? To hit a dog and the dog has died now. So what compensation you expect? We'll ask Ashwin only. What compensation you expect? I mean, what do you want to give, man? Don't smile. Money. She wants to, I mean, don't tell money. Money you want to give for the dog only, no? Say that clearly. Okay. So how much you want to pay? How much you want to pay? 2,000. Okay, that's so cheap. You think the dog you hit is probably a inferior breed to Pomeranian? Probably that's why you want to pay 2,000. Okay, whatever the dog's breed worth, you're going to give that particular money. Okay, so now the girl is asking 5 lakhs. What you will do? What you will do? Police call. You yourself will file an FIR. That's better. Okay, correct. Yes, that's what is correct. So that's stupid. Like giving a 5 lakhs to that dog, even though it's a life. I'm not making fun of it, but still giving 5 lakhs is something unacceptable. And if I am the case, I will pay a fine for both. I will hit the girl also, and I will run and I will pay the fine for both. So that's fine. So nevertheless, if you are paying, if Ashwin is paying 5 lakhs to that girl, then that is seriously wrong, which means either the girl must be extraordinarily beautiful, or trying something else with that girl, or probably, like you are a mental, you are a complete idiot. So that's why you're paying that 5 lakhs, which means Let us assume Ashwin is giving 5 lakhs for a dog that's died. And it is seriously wrong. I'll not call it as overcompensation. Remember, the body can never overcompensate. So don't try to confuse this with overcompensation. I can call it as an inappropriate compensation. It's not a correct compensation. Even though the compensation is happening, arrows might move in the same direction. It might not be correct, which might not be appropriate. It's not correct. So that's why even with the arrows moving in the same direction, you might not have an appropriate compensation. That's why you have to still find out whether it's a mixed disorder or a single disorder, even if the arrows are moving in the same direction. So that's why step 3 tells if the arrows are moving in the same direction, see the pH first. If the pH is less than 7.4, you call it as acidosis. If the pH is more than 7.4, you're going to call it as alkalosis. So make sure whether your problem is either acidosis or alkalosis for sure. That's the next step. Step number 3. It's a relatively simple step, so not a problem. Then we are moving on to the step number 4. In the step number 4, what I need to do is I have to find out the primary problem. Or, I mean, we are using very colloquial terms. I can find out the primary disorder. That's what I need to find out. Primary disorder. So now I'm finding out the primary disorder here. So how will you find out primary disorder? So it's very simple. So you see the pH. Let us assume a common example. pH is 7.2. Bicarbonate is, let us assume 14, and probably pH is 7.28. Bicarbonate is 14 and PCO2 is 29 in this regards. Okay. Let us keep this particular entity. Let us wait on this. Let us keep this fixed now. So now you know, first put the arrows. Always whenever you see this kind of a problem, always put arrows first. Bicarbonate is low, PCO2 is low, and I'm very sure that arrows is moving in the same direction. So 100% I'm sure it's not a mixed disorder. So that's what you have to confirm first. Now you know less than 7.4 means it's suggestive of an acidotic state, and both are moving in the same direction. So I know that. So I need to work up. So now I need to be sure that whether low bicarbonate is the primary problem or low carbon dioxide is the primary problem, because I need to find out which is primary and which is compensatory. Your pH will serve as a surrogate marker, because I told you now no disease can overcompensate, which means the pH should correlate with the primary disorder. That is the basic take-home point. How the pH will correlate with the primary disorder? Now you know low bicarbonate is the one that's going to produce acidosis. Low PCO2 is going to produce basically alkalosis. So this cannot be a primary disorder, which means it's against the pH. So low PCO2 cannot be a primary disorder here. So the only thing that correlates with the primary event is the low bicarbonate. So low bicarbonate must be the primary event here, which means I'm talking about a primary metabolic acidosis. And this low PCO2 that is happening is a compensatory alkalosis. And again, one more important point I want to tell is in textbooks, they would have given this as a compensatory respiratory alkalosis. That's what they would have given. But that's a very primitive and like UG level thinking. At a first year level thinking is to tell that compensatory respiratory alkalosis is there. But I believe that this patient is having a metabolic acidosis, but I don't want to tell it as a compensatory respiratory alkalosis, because this respiratory alkalosis or this fall in the CO2 that is happening because your metabolic acidosis is there. So it's a compensatory fall, and it's actually trying to save your ass by bringing the pH back to normal. So calling that as a separate disorder is, I don't think it's a right thing to call, and you're going to unnecessarily complicate your mentality and diagnosis. Here, the primary event is metabolic acidosis, and there is a compensatory fall in the carbon dioxide. That's all. So the compensatory fall in carbon dioxide, if you are very primitive, you can call it as a compensatory respiratory alkalosis, but it's better to avoid confusion. Don't call it a separate disorder, and it's like insulting that compensatory disorder. It's actually happening because there is some primary problem. So it's a compensatory fall in the carbon dioxide. That's all, nothing else. So now if you take another example, if you have a pH of 7.28, same condition, but I'm telling my bicarbonate is 30 and my PCO2 is 59. So here, once again, the patient is having acidosis, same pH, but here arrows are moving in the same direction once again. Both are increasing. Now I know very well that increase in bicarbonate will be alkalosis, and increase in CO2 is the one that is acidosis, because it's a volatile acid. And what is actually correlating the pH is the increase in CO2 only. So here it must be the primary event, and the compensatory event that is happening here, increased bicarbonate, is basically the compensatory event. This is not the primary event. So whichever is correlating with the pH, and that should be the primary disorder. So that's how you find out the primary event. And now you can understand how to find out the primary disorder in this kind of situations. Now done. So do you have any doubts in finding out the primary disorder? Any doubts in finding out the primary disorder? Any doubt you have? No. So now we know how to find out a primary event. So after finding out the primary disorder, the next step is to find out whether the compensation that is happening. Now you know at this step, at the step 4, you would be knowing that whether the patient is having, what is the primary disorder? Whether the metabolic component or a respiratory component. What is the primary event? That you will be knowing by step number 4. In step 5, you have to find out whether there is an appropriate compensation or not. You have to find out whether compensation is appropriate or not. As I told you with that girl example, now you might be having an inappropriate compensation also. So it's important to note whether the patient is having appropriate compensation or an inappropriate compensation. In this particular setting, how will you find out? Because there are some rules which tell you for this particular change in the bicarbonate or CO2, this much should be the change in the bicarbonate or CO2 in the compensatory event. So first, we'll talk about a metabolic acidosis in this setting. If it's a metabolic acidosis, you know the primary problem is the change in the bicarbonate. We know that. So change in the bicarbonate means, metabolic acidosis means it's a decrease in the bicarbonate. That's a primary event. And you know very well, as a compensation, your PCO2 also should decrease. This is a compensatory event. My question is, how much PCO2 should decrease to tell it is an appropriate compensation? It's a correct compensation, which means there is a rule for this amount of bicarbonate, this amount of PCO2 must only drop. Anything beyond that or less than that is considered inappropriate. So there might be a mixed disorder. So in this setting, how much low PCO2, which means that is called delta PCO2, which means how much PCO2 should change, I can give by how much bicarbonate has changed. Even though some textbooks will give 1.2 times, but this is very easy. So how much PCO2 should change, I can give by how much bicarbonate should change, which means for every 1 molecule decrease, sorry, I should write on the right side first. So for every 1 molecule decrease in bicarbonate, there should be 1 molecule decrease in the PCO2 from the normal value. For every 10 molecule decrease in the bicarbonate, there should be 10 molecule decrease in the PCO2 as well. This is what the rules are telling. I'm not telling this. So how can I tell this is correct or wrong? So it's quite simple. Now let us take the same example of metabolic acidosis. pH is 7.28. Can you hear me? Is there any problem that is going on? Can you hear me? Because there was some sudden glitch in my system that happened. Okay, that's it. Sorry for that. Okay, so I think everything is fine. Okay, 7.28. So pH is 7.28. So then you have this bicarbonate of 14, and you have a PCO2 of probably around 29. So this is what we saw, I think. So the previous example. So same thing I'm putting now. Now we know how to find out the primary disorder. So pH is low, it is acidosis. Both are moving in the same direction. This is basically acidosis. Because this is acidotic, this is what I'm considering a primary event. This is not correlating the pH, so I'll be calling it as a compensatory event in this setting. All these things we know already. And to go further, I need to find out whether this decreased PCO2 of 29 is correct or not. That's what I need to know, whether that's an appropriate compensation or not. Nevertheless, it's decreasing. So now, how to find out? So the delta bicarbonate or delta PCO2, how much PCO2 should change? That's what I need. How much PCO2 should change should be equal to how much bicarbonate has changed. Which means what is the bicarbonate that has changed? Bicarbonate normal value is 24 minus actual patient's bicarbonate is 14. Here it is 10. So 10 should be the change in the PCO2. Remember very clearly, this is a common mistake done by every student. This is the delta PCO2 that you have determined, which means you have only found out how much PCO2 should change from the baseline. You have not determined on how much PCO2 should actually be there. You have just found out how much PCO2 should change from the baseline. So 10 should be the change. You know what is the normal PCO2, that is 40, that's average, minus 10 must be equal to 30 plus or minus 2. So I'll be telling it is 28 to 32. So this is going to be the expected PCO2. So this is what I'm going to call it as a expected PCO2 range. So which also means that the patient's PCO2, if it is within the range, then that is actually quite expected, which means this is the PCO2 that I should expect for a bicarbonate of 14. Because the primary event is low bicarbonate, for that particular bicarbonate value, this should be the PCO2. And that's what I'm going to expect. And this patient, you're all going to tell now, this patient is having PCO2 in the expected range or outside the expected range. In the expected range or outside the expected range? In the range or outside the range? Of course, in the expected range. So because the patient's PCO2 is within the expected range, so I can tell this patient is having an uncomplicated single acid-base disorder. This patient is not having a complicated mixed acid-base disorder, only single uncomplicated acid-base disorder. That's all. And the uncomplicated acid-base disorder is metabolic acidosis, and there is an appropriate compensatory fall in carbon dioxide. Leave the confusion of partial, full, that one I don't want right now. Appropriate compensatory fall in carbon dioxide. You can call appropriate respiratory alkalosis. My diagnosis here is primary metabolic acidosis. That's a primary cause with an appropriate compensatory fall in carbon dioxide. That's all. CO2. This is my diagnosis. Very easy and not complicated. Now the same patient, pH of 7.28, bicarbonate of 14. Now I'm telling PCO2 is 34. Same patient, I have not changed anything. Now you will be expecting easily. If you work out the same problem, you will have the same issue. Everything is decreasing. You have acidosis. Your bicarbonate is 14. That is the one that is correlating with the pH. So it must be a primary event. This must be the compensatory event. There's no doubt about that. We know that all these things very clearly. But since I have not changed the bicarbonate, my expected PCO2 is not going to change. So even in this problem, for this value of 14 bicarbonate, my expected PCO2 will still be in the range of 28 to 32 only. So if this is going to be the case, so now I can see my PCO2 is now outside the expected range or within the expected range. That's the question. Outside the expected range or within the expected range? Definitely, it is outside the expected range. So now I know this patient should not have a single disorder. This patient is definitely having a mixed acid-base disorder. Mixed means what disorder? The one disorder I know, the patient is definitely having a metabolic acidosis. If it's mixed, I cannot tell primary. So this patient is surely having a metabolic acidosis. Plus, he's having a respiratory problem also. What is the respiratory issue he's having? That's what the question is. Is it respiratory alkalosis or is it respiratory acidosis? What the patient is having in this kind of scenario. Yeah, I'm getting mixed answers, but actually this patient is having a respiratory acidosis. For students who have answered respiratory alkalosis, you should always be sure. That's why I told you the common sense and the relativistic effect will come into play here. Remember, this is the CO2 I should have in a patient who's having a bicarbonate of 14. So which means this much should be the CO2 washout. The patient should have done that much of CO2 washout with a bicarbonate of 14. But this patient is not having enough CO2 washout to reach this expected range for this bicarbonate. Actually, if you take this CO2 of 34, it is more than what is expected for a bicarbonate of 14. So more CO2 than expected, which means more CO2, you're going to call acidosis or alkalosis. I'm going to call it as acidosis. So it's relativistic. It's not absolute. You have to be very clear about that. See, first year level biochemistry is all fine. Where you see low CO2 means always alkalosis. No. Here the patient is having a mixed event. In a single event, you can call it like that. But in a mixed event, it's always relativistic effect. The patient is having a relatively higher CO2 than what is expected for a bicarbonate of 14. So definitely this patient is having a associated respiratory acidosis, not an alkalosis. This is a very, very important one. So I can give a third example if you are still not very sure. So pH of 7.28, sorry. I think one side is gone, but nevertheless, that's okay. It came. Okay, cool. So pH is 7.28 and bicarbonate is 14. I'm taking hypothetical example. I'm not giving a what is that? I mean real-time example. Let us assume now the PCO2 is only 12. So even in this scenario, it's acidosis, and this is the one that results in acidosis. This is a primary problem. There's no change. Here the arrows are moving in the same direction. So, I mean, everything is the same. So now, since I have not changed the bicarbonate, it's still 14. My expected PCO2 is not going to change. Expected PCO2 is still going to be 28 to 32 only. So now you know very well, now the PCO2 is definitely outside the range. It's not within the range. Now I know, because the PCO2 in this patient is outside the range, now I know this patient is having a mixed metabolic acidosis, plus this patient is having a respiratory alkalosis or acidosis. This patient is having a respiratory acidosis or respiratory alkalosis. Definitely this patient is having a acid respiratory alkalosis. This is quite easy to understand. But remember again, why I'm telling this, because students will think because low PCO2 is there, I'm telling, no, it's not like that. Low PCO2 relative to the expected range. That's what I need to tell. So if the patient is having a low PCO2, this low actual PCO2 relative to the expected range, this PCO2 is less than what I'm expecting. That is why it is a respiratory alkalosis. So always compare with the expected range, not with the actual 40 or 38, whatever you think it is normal. This is a relative condition, so don't try to confuse that. So these are 3 examples I need to know. So what I'm trying to tell is, at the end of this 5th step, you will be knowing, most importantly, whether it's a single disorder or a mixed disorder. At the end of step 5, you will be knowing whether it's a single disorder or mixed disorder. Even if the arrows are moving in the same direction, you will be knowing that whether it's a single or a mixed. And please don't forget the relativistic effects. For metabolic acidosis alone, there are some tricks are there. So first trick is, I mean, this is delta formula is the standard, but you have something called a Winters formula also. There is something called a Winters formula, which is there for our this thing. For metabolic acidosis alone. Winters formula's advantage is it can directly give the expected PCO2. No need of delta business. Straight away you can have the expected PCO2. What Winters formula tells is 1.5 multiplied by serum bicarbonate plus 8. So this is what Winters formula tells. So with this formula, you can straight away find out the expected PCO2 without any basic need for this delta calculation. Straight away you can find out the expected. It's only available for metabolic acidosis, nothing else. So as per the Winters formula, you can take our original problem. So 7.28, 1429, right? So if this is the case, then 1.5 multiplied by, do the serum bicarbonate. That is 14, no delta business here, plus 8. So here you will get 14 into 1.5, 22 plus 8 is equal to 30. This is what you will get. Of course, I'm going to do it plus or minus 2. So 28 to 32. So for that matters, if you see, there is no much difference that you're getting with your delta formula versus the Winters formula. I mean, there might be 1 or 2 difference, but you don't really get that much difference with Winters formula. So that's correct. So same expect PCO2 you're getting, which means Winters formula is like a shortcut. You can straight away find out the expect PCO2 without finding out the delta calculations minus and all this stuff. And the next one is a trick that I want to tell. This is applicable only in real-time ABGs, but in exams it may not apply because they make up the ABGs in exam. So in real time, if you see from the beginning, in the first sentence which you have discussed, we have told that in the beginning itself that the last 2 numbers of the pH will typically correlate with the pH. I mean, PCO2 and the pH will correlate. Basically, the last 2 numbers of the pH will be almost correlating with the PCO2. That trick can be applied for metabolic acidosis, which means in this particular scenario, take the last 2 digits of the pH that is 7.28. So which means the expected PCO2 is 28 plus or minus 2. That is 26 to 30. This is the expected PCO2. Now I can straight away tell the PCO2 is within the range. Remember this sort of tricks, two problems. One, this will correlate nicely with your clinical practice, but in exam, I don't know whether it will work or not. At the same time, this is applicable only for metabolic acidosis. This will not be useful for other forms of acid-base disorders. That's a sort of a trick. So, I mean, there are three kinds of ways where I can find out appropriate compensation for metabolic acidosis. So now I have metabolic alkalosis. You have formulas for everything. For example, if it's a metabolic alkalosis, then I know the primary event here is rise in the bicarbonate. And as a compensation, I'll be getting rise in the carbon dioxide. This is what the problem here is. I mean, this is the idea, but I need to know whether this compensation is correct or not, because arrows are moving in the same direction. So in this setting, how much carbon dioxide should change will be given by the formula 0.7 multiplied by how much bicarbonate has changed. That is the formula, which means for every 1 molecule increase in bicarbonate, I'll be having 0.7 molecule increase in carbon dioxide. Similarly, for every 10 molecule increase in bicarbonate, I'll be having 7 molecule increase in carbon dioxide. So this is what is going to happen in the setting of a metabolic alkalosis. Number 3, what happens in respiratory acidosis? Remember, respiratory acidosis can be acute or chronic, but the basic understanding is in acute, you don't develop any much compensation, which means in acute, the change in bicarbonate will be very negligible and it is not appreciable and there will be no much appropriate compensation. Let us see. So what happens in respiratory acidosis? Here the main problem, primary parent event is the fact that the carbon dioxide is increasing. That is the primary event here. And as a compensation, your bicarbonate will increase. And remember, this bicarbonate increase will be negligible or if it's an acute disorder, which means there will be no much change in the bicarbonate and it will be sizable. Sizable means some substantial amount of bicarbonate increase will be there if it's a chronic disorder. And that's what we're going to find out using formulas. Suppose if it's an acute respiratory acidosis, in this setting, we need to know how much bicarbonate is going to increase. How much bicarbonate is going to increase, I can give by the formula 0.1 multiplied by how much PCO2 has increased. Based on that, I can tell how much bicarbonate should increase. But if you see, it's very negligible. For every 1 molecule increase in carbon dioxide, only 0.1 bicarbonate is increasing, which is absolutely negligible to negligible. Even 10 increase in carbon dioxide is going to rise only the bicarbonate by only 1, which means if the bicarbonate is 24, if the PCO2 becomes from 40 to 50, bicarbonate will become 24 to 25. And this is very negligible and I won't really appreciate that. That's why I told you in the beginning itself, normal bicarbonate. It will be in the normal range. As far as acute event is concerned, it will be in the normal range, 20 to 28. That's a normal range. If it's a chronic respiratory acidosis, then it will become sizable change, which means here also I can tell how much bicarbonate should change for a particular increase in PCO2 in a respiratory acidosis can be given by 0.4 multiplied by how much PCO2 should increase. Some textbooks will give 0.35 also, but nevertheless, everything is same. I can use 0.4 also. 0.4 multiplied by how much PCO2 should change in this scenario. I mean, will change in this scenario or already changed in this scenario. Which means I can tell for every 1 molecule increase in PCO2, there will be 0.4 increase in bicarbonate. For every 10 increase in PCO2, I'll have 4 increase in bicarbonate, which is actually substantial, which is a sizable change here. Clear? That is why in acute respiratory acidosis, as far as acute respiratory acidosis is concerned, the pH change will be dramatic. The pH change will be more. Why? Because this increase in PCO2 will change the pH so fast because the compensatory event is not happening properly. It's not that great. That's why the pH change will be so much. In acute respiratory acidosis, the pH will, suppose if it's 7.38 was the pH, the carbon dioxide increases by probably 15, the pH will drop to 7.28 immediately. There will be so much drop in the pH. That is because the compensation is not happening. Bicarbonate is not rising to compensate for the drop in the pH. But as in a chronic respiratory acidosis, the pH change will be negligible. That is because the bicarbonate change is sizable. That is why the pH change is negligible. For example, if 7.34 was the pH will still remain 7.34 because despite the fact that CO2 is increasing by 10 to 15, the bicarbonate also will increase by 4 to 6. So because of the sizable increase in the bicarbonate, the pH will not change that much. It will be maintaining in the almost near normal range. So that is the reason why the pH change will be very negligible in a chronic respiratory disorder. Any chronic respiratory disorder, the pH change will be negligible because your metabolic compensations are effective. Even though if it is late, it's very effective. Similarly, for respiratory alkalos also, you should have a similar kind of a derivation. This is the final thing I'm going to tell. It's going to be respiratory alkalosis. Now, you can tell that the primary event here is the fall in the CO2. That's the primary event here. And as a compensatory event, I'm going to have a fall in the bicarbonate. Now I need to know what will be the bicarbonate fall. So depending on acute or chronic, it will change. In acute, it will be negligible. Chronic, it will be sizable. So acute respiratory alkalosis, how much change in the bicarbonate I can expect is given by 0.2 multiplied by how much PCO2 has changed, which means how much PCO2 has decreased will tell you how much bicarbonate should decrease. Similarly, in a chronic respiratory alkalosis, how much bicarbonate should decrease can be given by 0.5 multiplied by how much PCO2 is decreasing. Based on that, you can tell how much bicarbonate should decrease. For example, in a chronic respiratory alkalosis, if 1 unit bicarbonate is decreasing, 0.5 is the unit change in the bicarbonate. If 10 decrease in carbon dioxide, there will be 5 decrease in the bicarbonate. This is the compensation. I mean, you can tell the same for acute also. Acute I have not written, but still, this is what I'm going to see in the setting of a respiratory alkalosis, acute versus a chronic respiratory alkalosis. So now at the end of this step, you know what you mean by appropriate compensation. And at the end of the step, you will be able to tell whether it's a single disorder or whether it's a mixed disorder. So this is step number 5. At the end of step number 5, I'll be able to tell it's a single disorder or a mixed disorder. That's the idea of this step number 5 in the first place. Finding out appropriate compensation. And if it's not appropriate, if it's outside the range, then you tell it's a mixed disorder. If it's within the range, you tell it's a single disorder. Finally, step number 5 is over. And all I need to know is that 4 magic numbers. 1 for metabolic acidosis, 0.7 for metabolic alkalosis, 0.1 and 0.4 for respiratory acidosis, and 0.2 and 0.5 for respiratory alkalosis. These are the 4 magic numbers I need to know. Apart from that, there's nothing else in the ABG in the first place. Then I'm going to go into step number 6. So now we are step number 6, isn't it? 5 year completed. We know it's a single or a mixed disorder. Now we are moving to step number 6. As far as the step number 6 is concerned, I'm going to find out the anion gap. So this is a mandatory step. This is a mandatory step. That is step number 6. No, where it went. Mandatory step. So I need to do this anion gap. Even if the entire ABG is normal, please trust my words. Even if the entire ABG is normal, even if my pH is normal, bicarbonate is normal, everything is normal, I need to do the anion gap as a mandatory step. So for example, if pH is 7.4, bicarbonate is 24, and PCO2 is 40, they will give problems like this. If you see this kind of problem, for God's sake, in exam, don't write this a normal ABG. I mean, please analyze. That's what I'm trying to do. It can be normal ABG, but in exam, usually there will be a twist. Whenever they give like this, it's not a normal ABG because they're trying to find something else. Based on the anion gap, you can tell that this patient is having a double disorder, in fact. Let me tell how. For example, they would have given sodium values and chloride values and other values. So for example, let me tell you sodium is 130 and chloride is 81. I mean, maybe for a simplistic purpose, we'll keep it 80. So now you know very well what's happening here. So now if the entire ABG, all the ABG looks completely normal. As per the numbers, everything is normal. Now I need to find out the anion gap as a mandatory step, even if the entire ABG is normal. If I find the anion gap here, the anion gap will be 130 minus 80 plus 24. So now my anion gap will be 26. Definitely I'm having evidence of high anion gap metabolic acidosis. This is a HUGMA. Definitely I'm having evidence of high anion gap metabolic acidosis. So whenever I'm having a high anion gap, now I have to find out the delta-delta ratio. So this patient is surely having a HUGMA, even if the entire ABG is normal. So now find out the delta-delta ratio. Anion gap minus 12. That is 26 minus 12 divided by bicarbonate. 24 minus bicarbonate. So 24 minus bicarbonate, 24 minus 24 is equal to 0 here. So here 14 divided by 0. Basically it is, the patient is having a infinity, which means it's definitely more than 2. So which means what I'm trying to tell is this patient is not only having a HUGMA, this patient is having an associated metabolic alkalosis. Without a doubt. Patient is also having associated metabolic alkalosis. We saw already. We have found out already. I told you the derivations. This patient is having associated metabolic alkalosis. Then why the entire ABG is normal? That is because this patient would have had a HUGMA. For example, a CKD. Now, which would have had a lower pH. Now he had developed a new episode of vomiting. So that has brought the pH completely back to normal. And everything has become normal because the pH was normal. So you can get these kind of problems also, but please don't do that mistake by telling this as a normal ABG. You have to see the anion gap mandatory. That's very, very important. That step 6 is anion gap. Then step 7 will be applicable if your result of step 6 is HUGMA. If you're sure that the patient is having a high anion gap metabolic acidosis or just an increased anion gap is enough. So either acidosis or not doesn't matter. Increased anion gap means you should definitely go through this step. That is finding out the delta-delta ratio. So if delta-delta ratio is less than 1, then there is a associated NAGMA is also there. If delta-delta ratio is more than 2, then an associated metabolic alkalosis is there in the patient. If delta-delta ratio is 1 to 2, then it's an uncomplicated HUGMA, high anion gap metabolic acidosis. That's all. If it's in the 1 to 2 ratio. Step 8. Suppose if your step 6 result is NAGMA, normal anion gap metabolic acidosis. The patient is having metabolic acidosis and the step 6 result is NAGMA. Then in this situation, you have to see the urinary anion gap. We know that. The urinary anion gap is positive, then I'll be thinking about a renal cause. If urinary anion gap is negative, I'm going to think about a GAT cause. Proximal RTA can produce both, like positive as negative, but nevertheless, this is very important for exam. Renal or a GAT cause can be differentiated by seeing the urinary anion gap. Then finally, you have step 9. Step 9 is applicable if it's only a single disorder. If you are sure it's a single disorder, then you will have a step 9 applicable. It's only optional. It's all optional steps only. Step 9 is applicable. So if it's a single disorder, which means I'm sure it's not a mixed, it's only one disorder. Both arrows are moving in the same direction. And the compensatory response is appropriate compensation and within the range of what we expect. So that's a single disorder. If it is a single disorder, we know in a metabolic disorder, the compensation will always be partial. So blind eyes, you can tell in metabolic disorder, always it will be a partial compensation. In a respiratory disorder, see whether it is acute or chronic. Acute or chronic. If it's an acute respiratory event, it will be uncompensated, which means the compensation will be extremely poor in the setting of a acute respiratory disorder. And a chronic respiratory disorder will be a full compensation usually. Usually this will be the norm. But remember, this will be applicable only if it is a single disorder. Metabolic means partial. Acute means acute respiratory means uncompensated. Chronic respiratory means it will be compensated. What do you mean by partial? pH will be still abnormal in a metabolic disorder, which means the compensation is not able to bring the pH back to normal. That's why we're calling a partial. In metabolic, it's always partial because the respiratory compensation cannot bring the pH back to normal. It's not that effective. In acute respiratory disorder, of course, pH will be abnormal because there's no compensation happening. Or if it's happening, means very negligible. It's not sizable. pH in a chronic respiratory disorder will be near normal. So when it is near normal, that's what should happen in a single disorder. If it's near normal, definitely it's a full compensation. This is what we call near normal, or if it's normal. Near normal means if it's somewhere around 7.35 to 7.45, even somewhere nearby. Even if I tell 7.34 is also very good in the setting because pH is almost becoming near normal, and that can happen only in a chronic respiratory disorder. So where the metabolic compensations will be late, but latest and effective, so that they can bring the pH back to normal. If the pH is normal or near normal, then I can tell full compensation. If pH is still abnormal, then it must be a partial or uncompensated. Usually in acute respiratory disorder, you can answer uncompensated. Usually in a metabolic disorder, you can answer it is a partial compensation. It cannot be a full compensation. This is what the idea of partial, full, or uncompensated disorder in the setting of different disorders. Then finally, step number 10. Again, this is an optional step. This step is more useful in a patient with a metabolic acidosis plus having a normal ketones and a normal lactate. In this setting, you can, if you're doing a toxicology screen, so during the toxicology, you can do something called osmolar gap, OG. That's why I told you, I will tell you what to do about that osmolar gap later on. So in the toxicology, I can find out the osmolar gap. There are a lot of toxins which produce an elevated osmolar gap. Like for example, methanol, ethylene glycol, all these things can produce a elevated osmolar gap. So what do you mean by osmolar gap? It's like an anion gap only. I'm going to calculate osmolality by some this thing, and I'm going to subtract that with the actual serum osmolality. Actual osmolality minus the calculated osmolality. This is the formula for the osmolar gap. So now the question will come, how will you calculate the osmolality? Based on the available values, I can calculate. A serum osmolality formula tells that my osmolality will be 2 multiplied by sodium plus blood urea nitrogen by 2.8 plus glucose divided by 18. Clear? So this is going to be the calculated serum osmolality. So if I know the sodium bun can be derived from urea divided by 2 approximately give you the bun. Then if I know the glucose, I know, I know the glucose of course divided by 18. So if you give this, you will get the calculated serum osmolality. But many institutes tell that you have to do ethanol by 4 also, because many of the times during toxicology, suppose the patient wants to take some toxin as a suicide, they mix with alcohol and drink. Alcohol also, sometimes if they take in too much amount, it can substantially contribute to the osmolality. Some institutions will tell that you have to take ethanol by 4 also. This also should be added if the patient has taken alcohol. Otherwise, it's not needed basically, if you know the alcohol value. So this is the osmolality. So whenever there is an osmolar gap, so in anion gap, we told like whenever cations minus anions we did, because it's positive, now you can tell that I'm not sure that I have measured all the anions, so I have left out some anions. That's what it means. Similarly, if my osmolar gap is more than 10, it is very significant. So what do you mean by significant? Because it tells you there is some missing osmoles. So which means what I'm trying to do is I'm calculating something. My actual mission value is something else, which means my calculated value is low. That's why the mission value is quite high. So what is the reason for the calculated value being low? Because I'm missing something here, some osmol. That is the toxicity. That is the molecule that I'm expecting. So whenever my osmolar gap is more than 10, it becomes significant in a toxicology screen, which means whenever osmolar gap is more than 10, when you consider some patient has taken a toxin, it might be an ethanol. If you have not calculated ethanol, it could be a methanol. It could be a ethylene glycol, or it could be a propylene glycol, or even it could be a oxoproline metabolite. That's a oxoprolinuria, oxoproline metabolite, which is coming from paracetamol poisoning. So which means in toxicology, this is very, very important. Whenever my osmolar gap is more than 10, I'm thinking about a missing osmol, which means in this particular setting, my calculated osmolality is lesser, which means I'm actually missing on some osmoles, which I'm not calculating. And these missing osmoles could be one of these things. That's why it's always advisable to take ethanol levels also. I mean, because if you know that, then you can exclude that and you can tell one of these must be there in appropriate settings. Suppose osmolar gap is less than 10, it is not significant, which means there are some toxins which does not produce osmolar effect, like salicylates. Typically, it goes towards a salicylate. Salicylates usually does not produce that much of osmolar effect. And similarly, like D-lactic acid, here also one confusing thing will be there. That's oxoprolinemia. That's why I wrote separately. This can be seen in either as a increased osmolar gap or a decreased osmolar gap. Doesn't matter. But in both these settings, salicylates are going to be the most important. If they give clearly osmolar gap is less, patient is having a metabolic acidosis, that is high N-gap metabolic acidosis, always it is a salicylate poisoning only. And this is a very common question in exam. So to complete our table, complete our metabolic acidosis discussion that we have done here. Here I told you, we can see the metabolic acidosis discussion I have made, and in the toxicology screen I have left blank. Why? Because in toxicology abscesses I will see the osmolar gap. If it is more than 10, I'll think about ethylene glycol, propylene glycol, methanol, and all this stuff, ethanol and all this stuff. If it's less than 10, I'll be usually thinking about a salicylate poisoning. That's the most important. Oxoproline metabolite of paracetamol poisoning can show either increased osmolar gap as well as a reduced osmolar gap. It's the same like that of D-lactic acid I told you for anion gap. So this is the final take-home point, and I think we have covered a detailed discussion on acid-base balance and so much physiology, underlying problems we have discussed. And these are the 10 steps that you need to know to find out any problem in the world. I mean, I don't think there'll be anything else. 10 steps, golden steps. And if you have any problems on your own, you tell. I'll give you 10 minutes of time. Now the time is 7:48. If you have any doubts, you can tell. Or if you want to give me any problems, we can solve. That will be more appropriate because I solved some problems, but if you give, it will be easier for me. Urinary, I mean, Ankit is asking how to find out urinary iron gap and urinary diversion. You cannot find out urinary iron gap. As simple as that. There's no need to find out urinary iron gap there. I mean, unless and until you go for some extravagant measures like doing an nephrostomy and taking a urine. So practically not feasible means who's asking you to find out urinary iron gap? No need. That's a logical question, but very silly. Not needed. Anything else? If you want to give problems, you can give. Okay, I have my own problem, which I'll be giving so that you can solve this. I'll post it in the groups. Maybe we can solve tomorrow, or you can solve the problems on your own and you can come and get back to me maybe tomorrow also, so that you can ask me so that it'll be easier for us. I have had my own problems. So this is the quiz I used to give to my residents. I mean, this is the last quiz I gave to my residents in my hospital regarding the ABG problems. I have 15 cases and I'll post it in the groups. So you can take these 15 cases and you can get back to the solutions maybe tomorrow. So if you have any doubts, if you cannot solve, then you can let me know. If you can solve, then that's not an issue. My intention is over. So you can take a screenshot now. Suppose if people who are not in the group wanted to solve this problem, you can take a screenshot of this problem so that I will remove my photo also. I removed my photo, so you can take a screenshot of this. And if you want to solve this, you solve tonight itself, because tomorrow if you solve, you won't solve. So solve tonight itself. And if you have any difficulty, you can get back to me anytime tomorrow. I think that must be fair enough. All right. I think there is enough time for you to take the screenshot. So I don't want to live further. So that will stop the today's session and we'll all meet tomorrow. Good night. Bye-bye. Same time. Tomorrow, I'm planning to start by 12. I'll intimate you in the groups, by the way. Pranav is asking, will there be sessions after 2nd October? Yes, there will be sessions, but I will tell you. But I am going for duty from 5th October to 16th October. So I don't know whether I'll be able to do sessions or not, but I'll try to do after 16th. By 18, 19, around that time I'll do. And even before that, if possible, I will do. But nevertheless, we have completed almost 3-4 topics I have completed. By tomorrow, nephrology, a lot of nephrology also will be completed. So I think you can work up on this these topics which I have discussed on cardiology, neurology, nephrology, and rheumatology till that. Even that will be too much. You will not be able to do it in 1 week. So do that first. And anyway, we'll be completing remaining things after that. In which group you are telling about time? In my Telegram group, both Telegram group as well as my WhatsApp group. Telegram is the biggest group. There are 25,000 people are there. If you want, you can join Kranti. Saurabh is asked, Seroderma have type 2 RTA. Rare. They can, technically speaking, any autoimmune candidate disorder can cause type 2 RTA. But rare. Scleroderma is more famous for developing that SRC only, scleroderma renal crisis. WhatsApp group I'll share maybe tomorrow. I don't think there is enough people. WhatsApp group is only 256, I think. So it's full already. If there is anyone, I'll share. Okay. Bye-bye. See you.